All right, we're finishing up the EMT course fundamentals unit here with lesson 5 on assessment, history, and physical exam for EMTs. This is one of the longer lessons. We're going to have about 2 or 3 hours of online independent prep work and then a 4-hour face-to-face lab. We need to spend tons and tons of time on assessment. It's a key skill, pretty much drives everything else, and something that we really want to emphasize heavily. So we're going to talk about how to integrate what you've already learned in the previous 4 lessons on safety, lifting and moving, then circulation, ventilation, oxygenation. Try to tie all this together and define some of the specific parts of patient assessment. And then in lab, we'll do some introductory scenarios so that you can apply this and start being able to apply some of the names and labels of things that you're doing to your assessment and treatment process. The first part of assessment is really kind of hard to explain. It's called the general impression. And for your National Registry Psychomotor Skills exam, they'll want you to actually verbalize this. And it's always kind of goofy because you never really verbalize this on a scene. So it's pretty much artificial, contrived for the testing. But I want to install that right off the bat here. Your general impression is something that you develop over time and experience as an EMS provider. But you can tell as you walk into the room, from across the room, from the front door, you take one look at the patient and you get a feel for whether they're sick or not sick, or you're not sure, or you get out of the ambulance at a trauma call. And as you walk up to the patient, suddenly your gut feeling is, this guy's really sick. And you don't really have a bunch of details or a bunch of evidence to prove that right now. This is a gut feeling. It's the little voice in your head. And so I personally try to limit the voices in my head to just one speaking at a time. But if I will listen to the little voice that says, this guy's sick, the little voice is right. He was right on my first day as an EMT, and he's right now many, many days after that. So it can't really explain it, but it's a little bit of an uneasy feeling or something. And so when they developed the assessment training and the assessment part of the curriculum, they wanted to include this. And it had several different names to start with, and they finally settled on general impression. And it's your gut feel. What they want you to do is just to pause for a split second and acknowledge that feeling. And in the registry test, they want you to actually verbalize it. So what we don't want you to do as you walk into a call is say, hi, my name is Bob, and my God, you look sick. That's not the purpose. They want you to listen to that little voice, but don't let it speak through your mouth. So general impression is you're across the room, sick, not sick, or I'm just not sure yet. Then you launch into your primary survey. Your primary survey is done rapidly, and you can do these things simultaneously. No one's telling you that you have to do airway first, start to finish, then breathing next, start to finish, then circulation next, start to finish. That's the old ABC of CPR, and that just doesn't work anymore. What we're really looking for is this circulation, ventilation, oxygenation assessment. And much of that can be done in conjunction with a hand on a radial pulse. So one of the goals of our teaching is that within 30 seconds, after it's safe enough for you to do so, we want you to have your hand on the patient's radial pulse. On a critical trauma patient, we'd like you to have a hand on their carotid and another hand on the other hand on the radial. We'd like you to have 2 hands on them. But say it's a generic guy having chest pain, sitting in a recliner in his house. You walk in, Mr. Smith, my name's Bob, I'm here to help. You are acknowledging your general impression inside your brain as you move up and say, how can I help? I'm here to help. I need to check your pulse, that kind of thing. And get down and touch your patient and get that radial pulse. And you can do a lot of your CVO from that position. So that initial CVO, that initial primary survey, initial survey, whatever you want to call it, should only take maybe 30 seconds. And then you want to move into emergent treatment. You need to establish an airway if one's not already there. If ventilation's not occurring, we need to support that. If oxygen therapy is needed, we want to get to that pretty quickly. You may want to get a pulse ox reading to really determine your exact oxygen therapy, but you can pretty well guess after your first CVO if you're going to need oxygen or not. And really, the pulse ox can be part of that O in CVO. Then if there's bleeding to be dealt with, deal with it. If there's urgent injuries like an open sucking chest wound, you want to deal with that. So you have your general impression, your initial primary rapid survey of CVO, and then emergent treatment. And now you're at your first decision point. And that first decision is about, do I have the help that I need? Do I actually need rescue? Is this a hazmat call? Is this a situation where law enforcement is needed? Am I going to transport this patient in this ambulance, or does it need to be a helicopter? Do I need more than one ambulance? Is this my only patient, or are there more patients? And do I need medics, or are the medics already dispatched? In most systems that we work with, and certainly our system, paramedics are dispatched every time. So that's kind of redundant, but it's good for you to think about that, because there are places in the state of Missouri right now and in other places nationally where 2 EMTs are staffing an ambulance, and they only call for a paramedic if they need one. So that then becomes a resource need at this decision point, and we want to give you a good list of that. This, again, is a pretty quick decision. So you've done your general impression, your initial survey, your CVO. You've started some emergent treatments if needed. You've thought about resources, and then you think about, is this a critical trauma? If this is a critical trauma patient, I need to move right now to a rapid trauma exam. If it's not a critical trauma patient, then I'm going to do what's called a focused history and physical. Focused history and physical. So if it's critical trauma, we need to understand right off the bat that critical trauma patients get better in trauma centers treated by trauma teams led by a trauma doc. They don't get better in the field. We need to move rapidly to the trauma center, do as much good, helpful stuff as we can on the way. Don't do anything harmful, but we need to get moving. So that's not a freak out, let's just go kind of thing. That is a let's get going. We need to get moving because the definitive care for this patient is not going to be provided here or en route. It's going to be at the trauma center. So maybe I've already found a wound or an injury or a situation where I've decided this guy's a critical trauma patient. Maybe he's got a gunshot in the chest. I need to do a rapid trauma exam to find any other life-threatening injuries. I need to find all the life threats, not just the most obvious one. So a rapid trauma exam is just that. It is rapid, no more than 60 seconds, full body sweep where I'm feeling and squeezing, looking for bleeds, looking for other major injuries, a rapid trauma exam. I can spend 5 or 6 seconds on the head, 5 or 6 seconds on the neck, maybe 10 seconds on the chest and belly, a few seconds on the pelvis, a few on each femur. I'm not looking for every little injury. I'm looking for the critical injuries that kill patients, critical trauma that kills patients. And as soon as I know that I have a critical trauma patient, I need to transmit a trauma alert to the trauma center. The trauma center has the trauma team. The trauma team is not standing in the ER of the trauma center just sitting around waiting for a critical trauma to roll in. They have other roles, other duties, and they need to be summoned to the ER. It doesn't do my patient very much good at all for me to arrive at the ER to see the trauma team and the trauma team hasn't been notified. So we need to transmit a trauma alert. We'll work on that with you in lab to find out what that sounds like. But otherwise, if your patient's not a critical trauma, you do a focus history and physical. Part of it's history, part of it's physical. Not just history, not just physical. It needs to be history and physical. And it's focused. That means we're going to look at what the main problem or main body systems are that are involved. So if I have a patient with a twisted ankle, he's not a critical trauma patient. I'm going to do a focused history and physical on the ankle and the ankle injury. I'm not going to start with feeling his head and looking in his ears and behind his ears and listen to lung sounds. I'm going to focus on what his main problem is, and then eventually I'm going to check everything else. What if it's a medical? Let's say the guy's having chest pain. Sitting in his recliner at home, watching a ball game, having chest pain. You show up, your general impression is sick from across the room. You don't say that out loud, but you move quickly over to his side at the recliner, and you do your CVO with your hand on his radial pulse, and you determine that if there's emergent treatments that are needed, if he needs oxygen or needs ventilation or needs airway control, and you start doing those, and you think about resources, and you probably don't need any rescue or hazmat or law enforcement or a helicopter for this guy, but maybe you do. So you figure out what else you need, and then you say, is this a critical trauma patient? Well, no. It may be a critical medical patient, but he's not critical trauma. So I don't need the rapid exam. I don't need the trauma center alert. I need to do a focused history and physical. I need to focus on his chest pain and ask him history questions about chest pain and do a physical exam about chest pain. And I need to focus on his respiratory and cardiovascular body systems. I don't need to be asking him questions about his musculoskeletal system necessarily, or his integumentary system, his skin, or his reproductive system, or this or that. I wouldn't start with a neurological system exam. I'm going to focus on what the main problem appears to be at the time. I'm going to avoid tunnel visioning. I'm going to avoid jumping to a conclusion. I'm going to avoid anchoring onto just one thing that, oh, well, he said it was chest pain, so it's got to be this. I'm going to look for everything. I'm going to add some vitals in here. That's an important part of this. Vitals are recorded and reported in this order, and you should know this. You should come into lab knowing this. We're going to ask you this on the readiness check to see if you can even get in the lab and participate. Because remember, if you aren't prepped for lab, you don't get to take up space in lab. So this would be vitals. We would ask you about this. And this is the way you write them. You can get them in whatever order you want, but you want to write them down and then report them to other people in this order. BP, blood pressure is always first. Then put a dash, then put his heart rate, then put a dash, then put his respiratory rate, then put a dash, and then put his pulse oximetry reading, his oxygen saturation. Then put a dash, and if there's other vitals you're going to use, like maybe you took his temperature, maybe you did a Glasgow Coma scale on him, which you don't even know what that is yet, but we're getting there. Maybe you're going to keep track of his pain. A lot of people think that pain is a vital sign. I'm cool with that. Maybe you're going to use capnography on this patient, whatever. But your main core vitals, full set of vitals, as they say, is BP, then heart rate, then respiratory rate, then oxygen saturation. Now, maybe you got them in a different order. That's fine. Then just put a dash and leave a space. Maybe you got his respiratory rate first, and then you measured his BP. So put BP, dash, leave a space, dash, put his respiratory rate, dash, then you get a pulse ox. Record these and report these always in this order, even if you get them in a different order. That's the first part of history and physical. The second then is going to be the history, and we're going to run through sample and OPQRST here in just a second. And then you're going to do a detailed physical exam. That's different than the rapid exam we talked about earlier. The rapid exam takes 60 seconds and checks big life threats. The detailed physical exam checks everything and takes a lot longer than 60 seconds. So I already preached about this, the full set of vitals, record them and report them in this order. And here's sample. Sample history. This is flashcard stuff. This is definitely on the readiness check for the lab. This is part of your entry ticket to get in the lab, is that you know these to a reasonable extent. So the word sample is helps you remember signs and symptoms for S, A for allergies, M for medications, P for pertinent past medical history, L is last something, and E is the events leading up to this. So let's go through these one at a time. Guy sitting in his recliner having chest pain. We ask him about other signs and symptoms. The S is not chest pain. The S is other things he might be feeling. He might be nauseated. He might be short of breath. He might be sweaty. He might be weak and dizzy. We ask him about, is there anything else bothering you? We ask him, do you have any allergies to foods or meds? Then we ask him, what medications are prescribed for you? And if he tells you, are you taking those? Is there anything else you're taking, anything over the counter or herbal preparations or something? Then we ask about pertinent past medical history. Pertinent past medical history. Have you had chest pain before? Do you have any heart problems? Do you have any lung problems? I'm not interested in whether or not he had an ingrown toenail removed when he was 7. I'm not interested in things that aren't pertinent. I'm interested in pertinent past medical history. Then I ask him, when was the last time you maybe ate something? And if so, what'd you eat? And did that make your pain better or worse? Last time you took your medicines, last time you had chest pain. Maybe I say something really personal, like when was the last time you had a bowel movement? If it's a woman of childbearing age, it may be appropriate for me to ask, when was your last menstrual period? Whatever makes sense. And none of it makes sense right now, I don't think. But as we work through various conditions and cases and scenarios in the labs, it'll start making more sense. For right now, just know that the L stands for last something. And then E is events leading up to this. What were you doing before this started? Not what were you doing when it started. It's what were you doing prior to that. And that'll, again, make more sense when we talk about it in a specific scenario. So here's OPQRST. Now, OPQRST is another part of gathering history, but it really only applies to pain. And it can be any kind of pain. It can be chest pain, foot pain, tooth pain, head pain, butt pain. It can be any kind of pain, but it doesn't really work for shortness of breath or nausea. Sort of does, but not completely. So really think of OPQRST as a way to drill down on a person's pain. The O stands for onset, and the way you ask that is, what were you doing when it started? Then the P stands for provocative or palliative, which means what makes it better or worse. So if the guy's having chest pain, sitting in his chair, you say, does anything make it better? Well, yeah, it gets a lot better when I lean forward, or it gets a lot worse when I stand up and move around, or it gets worse when I take a deep breath. What makes it better? What makes it worse? The Q is for quality. What does it feel like? And sometimes the way they'll describe their pain will help us figure out what's causing their pain. They may say pressure, heavy, squeezing, sharp, stabbing, burning. They may have all kinds of different, but what's it feel like? Then radiation is the R in OPQRST. Radiation means, does the pain stay in one place or does it move to others? So the pain started in his chest, but it's now moving also into his arm and jaw. It radiates, or it radiates through to the back, or so the pain goes other places. The S in OPQRST is for severity, and that's on a scale of 0 to 10. If 0 is no pain at all, and 10 is the worst pain you can imagine, where is this on your scale of 0 to 10? And time is easy. This is what time did it start. Now I'm going to mention something here, so hang on, maybe make a note or two. I'm going to go back to sample. The E in sample is, what were you doing before this started? O in OPQRST is, what were you doing when it started? And the T in OPQRST is, what actual time on the clock did it start? So for the guy in the recliner with chest pain, what have you been doing today? Well, I mowed the yard. What were you doing when the pain started? Well, I was sitting in the chair. What time did that start? 1:15. So now we have answers to those sorts of questions. You may also find history clues other places. And what if your patient can't talk? What if your patient's unable to give you any information? There's nobody around to help. Then you need to look for history clues in other places. Maybe that will be medicine bottles or a list of meds. Maybe he has something hanging on his refrigerator, called a file of life. Maybe there's something in the refrigerator. It's a pill bottle called the vial of life. And in that file or inside that vial, you'll have a list of meds and some people to contact and some history and this and that. So when your patient's not able to talk, look around. Look around the house. Check for a wallet, check on their purse, check on their phone. A lot of phone apps may have some information that you can get on there if you can get in. And we'll talk to you about that in lab and figure out how to get into a phone on the emergency button side. Maybe there's a medic alert bracelet or a medic alert necklace, or maybe there's some scars or other clues you might find as you're doing your physical exam. So you're trying to get history, and history gathering is not just what the patient can tell you. Now you come to kind of your second decision point. You've had a chance to do some focused history and physical, And now, is this a time-critical diagnosis for which you would need to alert the hospital? Many hospitals have a team dedicated to each of the TCDs, each of the time-critical diagnoses. A trauma team, a stroke team, a STEMI team. STEMI means heart attack for now. We'll get into it further later in the course, but for now, just think heart attack. Patient having a heart attack, they need treatment right away. It's a time-critical diagnosis. The treatment is needed urgently, and their outcome is based on the time it takes to get that treatment. Same with stroke, same with critical trauma. There's some others. In some systems, you can do a sepsis alert for a patient having sepsis, and then there's some others that may be added in there. But anyway, when you get to this point, you finish your focused H&P, and you kind of have an idea what's going on. You want to double check that it doesn't fit one of these TCDs, and if so, you need to make that alert. At some point, you'll do a detailed exam. It's pretty time-consuming. On the rapid exam, we gave you 5 seconds on the head, but the detailed exam is going to take a lot longer. You're going to look everywhere, and the same thing on the neck, the chest, the belly, everything. It takes a while to do this. Some critical patients, you don't have time. You're too consumed with emergent treatment and ongoing assessment that you never really get to that detailed exam, and that's okay. As long as you were doing things that mattered, as long as you found all the life threats and were dealing with them and maybe didn't find every little thing, the detailed exam is what you do when you have taken care of everything high priority. Ongoing assessment happens all the time. You don't just do this once, you do it several times, and you always have time for this. Even if you don't have time for much of a focused H&P, even if you don't have time for anything more than one rapid trauma exam, you've always got time for another ongoing assessment. Well, what's in the ongoing assessment? It's the big stuff. It's the important stuff. It's vitals. And it's maybe other important things like if you were doing bleeding control and you check to make sure it's still controlled. If you had a patient with respiratory problems, you were listening to lung sounds, you recheck those. Maybe it's other vitals or a pupil size or a Glasgow scale or another neuro exam or something else. But it's the big things, the things you found wrong on your first pass, and big important things. It's CVO sorts of things. You also check on treatments that you've done as part of this ongoing assessment. How often do you do that? Here's something for you to write down. You do an ongoing assessment no less often than every 15 minutes. And on critical sick patients, no less often than every 5 minutes. So at least every 5 minutes on a sick patient, you're rechecking all these big things. So here's the summary. Going to wrap up here. We're going to come in and do an initial assessment. So that kind of starts with your general impression. Sick, not sure yet. Listen to the little voice. Then do your CVO. Check circulation, ventilation, oxygenation. A lot of that comes with a hand on a radial pulse. You can probably add a pulse oximeter in there. We're kind of estimating their blood pressure, but we're really thinking about rate, effort, and depth on ventilation. We're using the pulse ox or our judgment to decide on oxygen therapy. We're looking for signs of shock. So does this patient have altered mental status, cool, pale, clammy skin, rapid heart rate, extremely slow heart rate, very rapid breathing, very slow breathing? It's the big stuff. It's the cardiovascular system, the respiratory system, neurologic system. It's the big three. Then, if there's emergent interventions that need to be done, bleeding control, airway control, ventilation, then we jump in and start doing that. And then you get to your first decision point where you say, do I need any different resources or more of what I've got? And then is this a critical trauma? If it's a critical trauma, then I got to do a rapid exam, and we need to get going. If it's not a critical trauma, I'm going to do a focused history and physical, and that may lead me to a time-critical diagnosis. I may find that this is a stroke. I may find STEMI or something else I need to alert on. I'm going to do ongoing assessments at least every 5 minutes on sick people, and the most critical patients get continuous ongoing assessments. Then when I have time, I'm going to do that secondary, that detailed history and physical. I'll get repeat vitals continuously, but I'll do that detailed history and physical where then I ask all kinds of questions and I look at all kinds of things and I find every little thing that's wrong. If you're operating as an EMT in a first response role, sometimes you have 30 seconds between your arrival and arrival of the paramedic ambulance. Sometimes you have 30 minutes. So how much you get done is based on how much time you've got. But this is the order that you do it in, and you work your way down this as efficiently and effectively as you can. And if you get interrupted, well, then you were doing things in the right priority order. You don't start with some silly detailed exam looking for every eyelash that's out of place and every minor little silly injury and asking ridiculous questions that don't mean anything. You don't start with that. You start with CVO and emergent interventions. And then you make decisions about, do I need more resources? Is this critical trauma? In which case I branch off. I say, we need to get going. Prepare for rapid transport. I'm going to check him to find every life threat. And we need to be moving off this scene, or at least ready to be transported ASAP. But if it's not critical trauma, then I'm going to look at focus, history, and physical. I'm going to ask him questions about the body systems that are involved, determine if I have a time critical diagnosis, and if so, make that alert. Keep doing my ongoing assessment. And at some point, I may have time to do a very detailed history and physical. So that's the framework for EMT level assessment. There's terms in there to know. There's some flashcard work for you to do on sample and OPQRST. So go back to those and look at those slides. Think about what it stands for and how you're going to ask it. I don't just care that you know that R stands for radiation. I need to know, how are you going to ask that? So work on that sort of thing. Review your CVO. Go back to the start of this unit and review the safety lifting and moving stuff that you've learned and practiced already in a lab. And review your circulation, ventilation, oxygenation, all those sorts of things, because this first fundamentals unit is truly fundamental and foundational. We need to build a strong structure that is based on these foundational concepts. So we'll see you in lab, and this should be really fun.